Welcome to rePROs Fight Back, a podcast where we explore all things reproductive health, rights, and justice. I'm your host, Jenny Wetter, and I'll be helping you stay informed around issues like birth control, abortion, sex education, and LGBTQ issues, and much, much more. Giving you the tools you need to take action and fight back. Okay, let's dive in. Everyone. So before we started today, I wanted to say thank you to the people who reached out because they liked our new intro, and especially to the people who reached out to comment that they were glad I talked about imposter syndrome. I'm glad that people appreciated that. It's important to talk about. It's something, like I said, I struggle with all the time. So it's nice to put it out there and hear that other people have the same problems too. Kind of demystifies it and makes it easier for us all to talk about it. So this week, I was thinking there's been so much going on. You know, right now, impeachment was just wrapping up. The Iowa caucuses, where I think the technical term is a shit show. And there's just been so many other things happening. I've been working on a lot at work and had a lot of deadlines right now. So I've just been really stressed. And I know I talked about self-care already recently, but this is talking about it to hold myself accountable, that I am not taking the time I need to take care of myself. And it happens. You know, everything else gets prioritized and you forget. It's easy to forget to do the things that you need to do to take care of yourself. So, you know, I've been good about doing some of the smaller things. I've been sticking to my New Year's resolution of baking more bread. I've been making something every weekend, but I've been really bad this year about meditating. And I've just been reading before I go to bed and just so tired that I've not taken the time to meditate, which helps me sleep better. And so I'm in a really bad stretch again of not sleeping. So I want to get good about meditating again. So this is me putting it out there that this is important to my self-care. I know it is. And so I need to prioritize it. And so for anybody out there who is also not being good about prioritizing themselves, let's do this together. Make ourselves the priority and do what we need to do. So one of the things I need is if anybody can recommend a really good meditation app that they enjoy, I would love to hear what is working for you all. Feel free to reach out on social media. We're at rePROs Fight Back on Twitter and Facebook, and rePROs FB on Instagram. Or you can email me at Jenny, that's Jenny with an IE, at reprosfightback.com. And I would love to hear what people are doing and what you're loving. Okay, so with that, let's turn to this week's episode. I am really excited about this week's episode. We are going to talk about something that has come up in multiple episodes, but we haven't done a deep dive on it yet, and that is Medicaid. I'm really excited to have with me Jamille Fields Allsbrook with the Center for American Progress. So with that, let's turn to this week's interview. Hi, Jamille. Thanks so much for being here.
Thank you so much for having me, Jenny.
I'm really excited to talk about Medicaid today.
Yes, Medicaid, so exciting. Glad. So it often gets ignored as not that exciting, but I'm happy you all are doing it because it's critically important.
Yeah, and I think most people are familiar with Medicare and not realize that there is a separate program called Medicaid. So maybe we'll start there. What is Medicaid?
Sure. So Medicaid is a health coverage program for certain low-income people. It is both a state and federal program. Distinguish it from Medicare, which you mentioned more people know about, which is the program for older adults, people, specifically people over 65 and certain people with disabilities. But Medicaid, as I mentioned, covers certain low-income communities and people. And the reason I say certain is because historically Medicaid has required that you be not just low income, but low income and have some other category of eligibility. So low income and a person with a qualifying disability, low income and blind, low income and a caretaker of a minor, low income and a child. And I always like to make that distinction because a lot of people think like, oh, all low-income people can just get on Medicaid. And that has historically not been true. People probably, and we'll probably talk about this some, but the ACA sought to remove some of those category requirements. So in some states, if your state has expanded Medicaid, it is just you be low income and meet the income eligibility requirements and certain burdensome citizenship requirements also.
Yeah. So, I mean, it's really not that simple to be like, who's covered, because it does kind of vary state by state because of the Affordable Care Act.
Yeah, and that's why I'd also like to remind that it is a state and federal program, which is different. People, like you mentioned, might know Medicare more, which is a purely federal program, where Medicaid is both a federal program. Funding comes from the federal government, but funding also comes from the state. Federal government sends certain minimum eligibility requirements, certain benefit requirements, but states then still have a lot of flexibility, which I know we'll talk about.
Yeah,
for better and worse.
Right. So what is covered under Medicaid? Is it everything? Is it most things?
Yeah, sure. So Medicaid does offer a robust benefit package, and it has certain minimum benefit requirements, as I mentioned, that all states have to cover. So one that's most very likely interested to the audience here is it covers family planning services and supplies, which states can define sort of what that means, but it includes contraceptives and certain screenings, cervical cancer screenings, STI screenings. But Medicaid also covers other benefits like maternity coverage, covers services that many other health programs might not cover, like non-emergency medical transportation. That is exactly what it sounds like, transportation, getting to and from non-emergency healthcare visits. So it could be a very robust program and also covers many of your other basic coverage that you would think about: hospitalization, emergency care, et cetera. One thing that is worth noting is not only does Medicaid cover family planning, Medicaid is the largest public funder of family planning services and supplies, covering about 75% of all public dollars spent on family planning. And Medicaid also covers 50% of births in this country. So critically important. Some of us could call it, a women's health program, given the services it covers and the people that it cover, but it also could be just as quickly described as a family planning program.
Yeah, and I think it's really important. In our last episode, we actually talked about Black maternal health and access to healthcare and abortion restrictions. So kind of together how they are impacting Black maternal health. But clearly, Medicaid is also a really important program in Black maternal health.
Yes, no, thank you so much for bringing that up. It certainly is, due to systemic racism and other structural barriers, Medicaid covers a disproportionate number of people of color, particularly Black and Latina people. And given the fact it covers 50% of births in this country, how the Medicaid program is structured, what benefits it offered, the accessibility to it impacts our maternal health crisis. And as you mentioned, Black women are 3 to 4 times more likely to die from pregnancy-related complications. Native American women also around 3 times more likely. So it is, defies logic when we talk about some of these restrictions around Medicaid to think that in the middle of such a public health crisis, we would try to scale back the Medicaid program or change, eligibility or anything else related, because it is such a lifeline for those communities. And, like I said, we're in the middle of a crisis, as you all talked about last episode.
Absolutely. So the other one you mentioned is the family planning program. So I think that's also another one where it's hard to talk about who's covered because it does kind of vary state by state, because some states have really expanded who that population is because they can expand their program beyond the federal minimum. But maybe we want to touch a little bit on the family planning program.
Yeah, sure. So as I mentioned, Medicaid covers a robust benefit package of family planning within the program. And so if you're in a state that has expanded Medicaid, then states under the ACA, then the eligibility requirement is very wonky, but it's 133% of the federal poverty level. If you are below that, then you're eligible. Now, if you're in a state that has not expanded Medicaid, then it'll vary. And it, as you mentioned, because it varies state by state, it's hard to just give a, definitive answer. But some states, it might be if you're 50%, some states if it's 100%, some states if it's, 75% of the federal poverty level, then you'll be eligible. It also means that there are some states who have graciously expanded other limited pathways to be enrolled in Medicaid. So there are some states who have what's called a family planning waiver or a family planning state plan amendment. And those states, even if you don't qualify for the general Medicaid program, you might just be able to qualify just to be able to access family planning. Similarly, some states have also created or adopted a narrow pathway to Medicaid for the pregnant, if you were pregnant. And back to what we were talking about with the maternal health sort of crisis, one thing that many of us have been advocating for is that if you do qualify for that pregnancy-only pathway, that you be able to qualify for the full extent of benefits, which isn't necessarily true in every state, and also that you remain eligible past just 60 days, which is the current only requirement, that you might be eligible only for about 60 days following giving birth or following the end of the pregnancy. And so, 60 days is nothing, as a mother would say. And so, those limited benefit programs like the family planning, like the pregnancy-only pathway are great and great expansion, but it's even better if a state just expands their Medicaid program, which all but 14 states have done, but we'll keep working on them.
Yes. Yeah, 14 states have still not expanded, which is kind of mind-boggling to me. Like, why wouldn't you want to ensure that your lowest income people have access to comprehensive health care? Like, it boggles my mind.
Yeah, they have all the incentives. As I mentioned, you get federal and state funding, covers the Medicaid program. If you expand your Medicaid program, then the federal government kicks in even more. It was the federal government would pay 100% of that cost. Now it is they will pay around 90% of the cost. So, why won't states do it? I have my theories, politics perhaps.
Yes.
But it definitely is in the best interest of the citizens of the state if a state were to adopt and expand. And because not only does it expand, and I said this before, but just to sort of harbor on the point, not only does it expand like the income eligibility, but also removing those categories, those burdensome, can you check this box and that box? And, because it is true that, like, I'm from Missouri, in my great state of Missouri, there not only do you have to meet like a very low income, a requirement that's, like super low. And so you could be low income and still just not low income enough. Or to put it plain, as my mom would say, not poor enough to qualify. But then you also have to say, well, I am a childless adult, so I still don't qualify. I am a struggling student, maybe making only, a small amount of money, but I don't have any children. I don't have any disability. I don't have any of these other category requirements. So I still don't qualify. And, that's not just to pick on Missouri. That's true in all those states that didn't expand.
Yeah, no, that was particularly striking when I was first looking at the barriers to accessing Medicaid in those states that haven't expanded. As similar to you, I'm from Wisconsin, who has also decided not to expand. So it hits close to home.
Right.
Okay, so we touched real quick on when we talked about the family planning program, the idea of a waiver. So what's a waiver?
Yeah, so under the Medicaid statute, states, as I mentioned, because the federal government, because it is a federal state program, federal government has certain minimum requirements that states have to adopt in order to receive the federal funding. But the statute does allow states to get what we call a waiver in order to say, I want to adapt my program in certain ways. Now, they can't adapt their program in every way. And it is supposed to be something that's experimental and promotes the Medicaid program, which is promoting health coverage and access to care. But states can submit these waivers. And waivers can be a good thing. States have done, some good things with their waivers. You've seen sort of new innovative models to change how you deliver care, delivery system. So how care is delivered in the state. You have seen before sort of the ACA, states had used the waivers to expand access to people who otherwise might not have met some of those eligibility requirements. But now you also see waivers used in not so great ways to also change some of those things around the Medicaid program, including, trying to impose some additional cost sharing requirements on people who, and, some of these requirements, people say, oh, it's just a minimum amount, but study after study have shown that if you're low income, even a small dollar amount, you might not be able to qualify, or you might not be able to sort of access care. And you also see states trying to do things like imposing onerous work requirements and, other things that are contrary to what the Medicaid program is all about.
Yeah, so I think we have seen, like you said, kind of this onslaught of negative waivers. So maybe we'll do a little bit of a deep dive in explaining what they are, because some of them, maybe like at first blush, you don't understand how they could be prohibitive. And so first you touched on cost sharing. So maybe we want to dig a little bit into that. We don't need to go super deep, but.
Yeah. So under the Medicaid program, generally cost sharing is like limited or prohibited in many instances. And so some states, though, have these waivers in order to be able to impose more costs. And basically, and when I say cost sharing, just stepping back a bit, what I mean are things like you're covered for this service, you're covered for your prescription, but you have to pay more out of pocket when you go access it. So many of us, like if you have private insurance, you're probably used to that concept where you go to the doctor's office, my many doctor's office, they ask for your insurance card and say your copay is $30 or whatever it is. And so that practice has becoming increasing. You see more and more states trying to shift the costs upon these populations. And the reason, just to be clear, because, people think like, well, I have insurance and I have to pay a copay, so that's not too bad. As I said before, remember the communities we're talking about, right? The reason why people are enrolled in the Medicaid program is because many of them cannot afford to be on, to afford those costs of what it costs to do, be it in private insurance or otherwise afford to be able to access health coverage. And so you see things like, especially things like preventive services. So things like just going to your OBGYN, going to get that well woman visit, going to get a STI, HIV screening, those kind of things that, they're preventive. You go before it's a thing, before it's a problem. And so those kind of services are increasingly subject to people foregoing it if they have to pay, out-of-pocket costs that they might not be able to afford. So, think about the scenario of you're a mother of two. You could either go get your well woman visit and pay the amount of whatever it is that you have to pay out of pocket, or you need to pay your light bill and, to keep your kids with light and heat and, other things. That's not a decision,
No, obviously there's
exactly.
It's an easy decision there. You pay for your light bill.
Exactly. And so that's, sort of the danger of doing something like, sort of pushing more and more costs onto people. The other one that I mentioned was the work requirements.
Right. And there's a range of them.
Yeah. And so I'll say, even we call them work requirements. You might hear, if it's talking about in your state, it might be something like, community engagement. And you might think like, oh, that doesn't sound so bad. What's community engagement? Well, it is saying that, and they vary, but it might say, oh, in order to receive Medicaid, you have to work a certain amount of hours or be looking for a job for a certain amount of hours or, be in some sort of training program. And the reason why that can be so dangerous and prohibitive for people is because, first of all, the majority of people on Medicaid work. And so there have been some studies that were put out, including one from our friends at the Center on Budget and Policy Priorities have done analysis, people at the National Health Law Program who've put out great work that talks about like who is impacted if you impose those work requirements. And 60% of the people who would get these work requirements imposed upon them are people who already have a job. They already work. And maybe they don't work the hours that would be required under a waiver. But many of them also will have a reason for that. Think about, again, back to the scenario about sort of a mother who might have, the cost. I'm not a mother, but from what I hear, the cost of childcare is expensive. And so many might make the decision, it's actually financially better for me to be at home, take care of my children, than to go out in the workforce. And also not just financial, but also might be better for the children. And so in that kind of scenario, you would be putting a person in a situation to say, well, either, you stay at home with the child or you lose your health coverage. You kind of, choose. And in fact, when this attempts were put upon or tried in Congress, even a Republican-controlled Congress rejected them in 2017 when we saw the ACA repeal, it was the majority of people who would have these work requirements imposed on them were women. And, draw that bridge back to what we talked about with access to family planning services and supplies and who was harmed. It is, again, women, which, we used to get in the short end of the stick at this point. But, that is sort of, again, some of the dangers of something like a work requirement.
So beyond work requirements, there's also been a slew of lockouts. Do you want to talk a little bit about what those are?
Sure. So you also have things where, and it relates to sort of the work requirements. It works to some of the other sort of dangerous waivers we talked about, where if you don't meet sort of whatever the state is requiring of you, so perhaps you didn't meet the work requirements, then not only get kicked out of the program, but also might have a period of time where you can't get back in. And so, again, you're talking about people who, need that access to healthcare and who now you are not only taking their coverage, but you're also saying, well, you won't be able to get back in. And in what way is that a benefit for people's healthcare? What way is that a benefit for public health? Where you're saying, well, we know you need this health coverage, but you just still won't. We're not going to allow you even to get back in because you didn't meet whatever requirements we tried to impose upon you previously. It is, contrary to everything that sort of the Medicaid program is about.
Yeah, so far these all seem very much like we just don't want to give you healthcare, and we're going to give it as many barriers as possible to ensure people aren't getting it.
Yeah, for sure. And I should have started off and sort of put it as a context that, remember, this administration came into office saying they were going to repeal the Affordable Care Act and transform, quote unquote, the Medicaid program. 2017, we saw various failed repeal bills. I had to stay up reading them all. I won't even go back into that. They'll give me flashbacks. But
so many protests that summer.
Exactly, so many. I started keeping my tennis shoes in the office. But that failed. Voters rejected it. Like I said, even a Republican-controlled, conservative-leaning Congress rejected it. And so now what we see are all of the things we just talked about, including we haven't even gotten to try to transform the program to a block grant program. All of those things were in those failed bills. And so now we just see them trying to do the same thing administratively. So you're right when you say like, oh, it sounds like you're trying to put all these barriers that will take away people's healthcare. Well, that's exactly what they're trying to do. They're trying to put all these sort of, where they couldn't do it sort of with a sword, just cut it all off. Now it's like a chip away, but the result is still the same.
Wow, this takes me back to so many conversations about what's happening with Roe.
Oh, right, exactly. Always it's the same. Oh, you know what? That's such a good I hadn't made that sort of mental sort of line. That's why you are who you are, Jenny. But it is very true. It's like, we don't like it, so we're going to chip away at it.
Until it basically doesn't exist.
Exactly.
But it still exists.
Exactly. And so they can say like, oh, it's still there. Like, we didn't take away people's health coverage. Yeah, but you did.
Right, exactly. So, okay, where do you want to go next? Texas or dig into block grants?
Oh, I'll talk a little bit about Texas because that's also a waiver that was approved. Actually, they're both are, but
So, this is getting into much more current. Mm-hmm. So the other ones have been ongoing for the last little while. The Texas waiver and block grants just came up in the last 2 weeks.
Yeah, I know, right?
Which is wild. So let's talk about what happened in Texas.
Yeah. So again, back to sort of the same concept we're talking about how this administration is approving these waivers. That basically was like, it states, if you do what we think you should do, then we will approve your waiver and you could use federal funding to do it. And a prime example of that is what we've been calling sort of this Texas waiver. But in short, what they did on the Roe anniversary, nonetheless,
of course,
was to approve a waiver request that has been out there pending for quite some time that will allow Texas to remove certain requirements that people get to choose sort of the provider of their choice, and allow Texas to remove that sort of wonky provision in order to kick out certain family planning providers. And so that would mean that, and when I say kick out, that would mean that these family planning providers wouldn't be able to receive Medicaid funding if a person comes in. And so, think about that again practically. If you're a person, you have Medicaid coverage, you decide to go to your local family planning provider because that's where you've always gone to get your OBGYN.
Where you can get an appointment.
Exactly, where you can get an appointment because
in a timely manner.
Right, because we won't even get into the whole sort of like, there are some providers who don't want to take Medicaid enrollees because Medicaid doesn't pay that well. But, we can talk about that another thing. And so many of these family planning providers have been people's lifeline and access to care, access to not only the things we care about. I mean, we care about it all, but not only things, reproductive health services and STI screenings and cervical cancer screenings, but also just access to your regular visit. Many people consider, especially women, consider someone like their OBGYN their primary care provider and don't know the difference. It wasn't until I got in public health, honestly, that I even understood that, that conceptually the healthcare system tries to put it different. And so these would limit people's choices of provider. And to be clear, Texas has done this and tried this experiment before, and it's failed. And so Texas, back in, I think it was 2013, kicked out Planned Parenthood out of their family planning program. But then the federal government said, well, you can't use federal funding to do this. And so what happened a couple weeks ago was they said, well, you can use federal funding to do this. And it'll impact, like I said, providers like Planned Parenthood, but also, to be clear, a range of family planning providers. And also the people who rely on them, most importantly. When Texas did this before, you saw, and this was a New England Journal of Medicine study that showed that there was a decrease in people accessing long-acting reversible contraceptive LARCs. There was a slight uptick in Medicaid coverage around births. And that's like sort of the scientific study. And I'm sure there's numerous anecdotes out there about people like, well, I just couldn't go to my provider anymore. And people might not understand sort of why. And, this is why.
And so I think it's also really important to note that, yes, we're talking about one waiver in one state, but it's like going to open the floodgates. There are so many other states that I think there's some that are already pending, but there are so many other states who are going to try and do this exact same thing.
Well, that's the concern, is that it's going to open the floodgates and set this bad precedent that other states will try and think like this is permitted and acceptable. And, again, back to, keeping with the same theme, things that they've tried to do in 2017 that didn't work out. Remember, the same ACA repeal lawsuit we talked about would have also prohibited Planned Parenthood from receiving Medicaid funding. And so now it's like that failed. People said no. And now we see like, okay, well, we're going to do that on a state-by-state basis now. We're going to try to. But states, again, the good thing about waivers is that it has to be a state driving this. So for those, people in state, if you get wind that your state is considering such things, then, it's an opportunity for people to speak up.
Yeah. And I think this is also just another one of those like basics, like reproductive healthcare is healthcare.
Right.
Like you need to go for these doctor visits.
Right.
And you need to go to people that are going to take your insurance and have appointments. And that is why this is could have such a huge effect.
Yeah. And that's another reason why I'm glad.
And one you trust.
Yeah. One reason I'm glad we're doing this conversation here is because people think about Medicaid as just sort of this sort of wonky, kind of arcane sort of program out here. And like, let's be very clear, like something like the Texas waiver is an attack on people's bodily autonomy. It is dictating where you can go access services, and it is making a statement about the kinds of services they think people should be able to access. Like, we're not talking about we're talking about family planning providers. We're not talking about, all providers. We're talking about a targeted effort to attack those who provide reproductive health services. And that is them making a judgment call about, good or bad about accessing reproductive health services, even though we know people have already made that call that the majority of people do. But
unfortunately, this was not the biggest Medicaid news in the last 2 weeks.
Yeah. So we alluded to a bit before, but also in this vein of still waivers, the administration sent out guidance to states inviting them to apply to transform their program into what's considered a block grant. And so stepping back a bit, I mentioned that Medicaid is funding by the federal government and it's funding by the state government, but it's considered what we call an entitlement program, which means that if you are qualified and you're eligible, then you should be able to enroll in the program. And it also means that the federal government provides states with the funding with this whatever percentage of agreement the state and the federal government have, they provide them with the funding that is needed in order to cover those people and cover those services that are covered. This is an attempt to change that. I know it sounds like a broken record, but back to that 2017 sort of bills would have also changed the Medicaid program and would have said, no longer is it this sort of needs-based sort of funded program. And instead, we're going to do what is called a block grant, which means we're going to give you a certain amount of money and and that's it. If a public health crisis comes and you need more than the amount of money we gave you for that year, states, you're on your own. If you get an increased amount of people who need eligibility or need services, states, you're on your own. And so it's a bad deal for states. It's a bad deal for the citizens within those states. And when you think about other types of programs, so Medicaid has to have things like a waiting list and things that you might associate with other health programs. This could create something like that and create sort of people waiting to get on the program. It also might force states to make hard decisions where a state might have to decide either we cut eligibility or we cut the certain services offered or scale them back. And so, it's very concerning.
Yeah, and I think one of the things that also seemed concerning to me hearing about the way this new block grant proposal was that if states didn't spend all the money, they could keep what they had left, which all I could see was states being like, oh, we're going to cut services and cut this, and now we have this extra money.
Yeah, there's something in there that they talk about like being able to, quote unquote, share the savings with the federal government. Yeah. And so, but to your point,
it was just a red flag.
Yeah, no, it is. And the incentives that it gives states is to say like, okay, well, if we can save the federal government money, then we get to take a part in cost of that savings, which, on its face might not sound like a bad idea, except for the fact of like, save money how? Save money by kicking people off the program, saving money by scaling back what the services that are offered. Like, how are you saving money? And the reason why, going back to how we started this conversation about the services that are covered under Medicaid, remember, if you kick people off of the Medicaid program, then you're also limiting many of those people's access to sexual and reproductive health services, as well as lots of other things.
This just takes me back to the State of the Union where he said we lifted 7 million people off of food stamps.
Oh, my goodness.
No, you kicked 7 people off the program that needed it.
Yeah.
And this just,
Exactly. And it's I'm a fan of the Medicaid program. I think can get a bad rap, but Medicaid, because many of the robust services that are offered under the program, and because specifically some of those unique services like transportation, some people fare well under the program. And there even has been some data out there about how people who Black and Latino people tend to have better health outcomes under the program. And that is because of all of the benefits it offers.
Yeah, it's just getting so frustrating, and trying to stay positive is even the right word, but like not get bogged down in the slog of like just this continual onslaught of proposed changes.
Yeah. And I mean, the good thing, and that's all I'll say on a positive, I always feel like every time I go speak somewhere, I'm always like the Debbie Downer. So,
yeah, I can't relate to that at all.
So on a positive note, again, with the block grants and all these waivers, it requires a state to apply and take action to do it. And so no state has put in place sort of this block grant. And if you get wind in your state of a state considering taking such action, then, as a citizen of the state, it's time for you to engage with your elected officials.
Well, that leads us perfectly into, while I do get to be Debbie Downer all the time and talking about all these terrible things, we do get to end with, what can people do to fight back? So what actions can people take around some of these issues?
So now that you know how important it is, pay attention to what's going on in your state. Pay attention if your state is seeking to apply for one of these waivers. One thing that is required is that there is an opportunity for public comment, which can also sound very arcane and wonky, but it is an opportunity to literally submit a letter, submit sort of stories, submit things about what you think could happen if such a waiver or proposal went through. And, get out, and even before your state sort of takes any of those kind of actions, let your elected officials know that the reproductive health community cares about these things and what it means to our community and the benefits that Medicaid offers. And you can start that education now. You don't have to wait until your state does anything. You can sort of put them on notice to not consider it. Because I will say, even, there are just some horrible elected officials out there, but there's also people who you might get swayed. Of course, the way sort of, especially think about the block grant guidance, the way it's written, it can sound persuasive to states. You mentioned you could take advantage of shared savings. And, it's on us to sort of educate them about that it's not good. It won't be good. And also, if you have a network of people and sort of citizens around you, letting people know why this is important and letting them know what this means for reproductive health, what this means for bodily autonomy, and connect those dots for people. I think it's very valuable because a lot of people might not realize sort of the potential impact that these waivers and other proposals could have.
And I feel like that's particularly true with Medicaid, since so many people are just not familiar with it.
Yeah, for sure. And it is true. And it's also true that many people, those of us who are enrolled in private insurance, can get sort of this thing it doesn't relate to me, it doesn't apply to me. But one, we know that people over the course of their life cycle, like change their health program. Like I can't even say how many times different sort of health insurance I've had. And sometimes that means people roll in and out of the Medicaid program. It also means that we don't want even private insurers looking at things that the state is doing with their health coverage program, thinking they're good models.
Right. Well, Jamille, thank you so much for being here and doing this. It was great to talk to you about Medicaid.
Thank you. Thank you so much for having me. I'm so happy you wanted to talk about Medicaid.
Thanks for listening, everyone. We'll be back in 2 weeks to talk about the upcoming Supreme Court case, June Medical Services versus Gee, looking at the Louisiana case. I hope you enjoyed the interview with Jamille, and we'll see you soon. Thanks. For more information, including show notes from this episode and previous episodes, please visit us at our website at reprosfightback.com. You can also find us on Facebook and Twitter at reprosfightback and on Instagram at reprosfb. If you like our show, please help others find it by sharing it with your friends, and please rate and review us on Apple Podcasts. Thanks for listening.